Are you ready? Ready. Thank you very much. Good afternoon, everyone, and thank you all for being here or on screen. And just to remind everyone that this is a public meeting and it's being live streamed. When you speak, if you'd like to introduce yourself so that everybody listening and everybody here can know who you are. So on to agenda item 1, apologies. Melanie, please, George.
Yes, we have a couple of apologies this morning. We have apologies from Councillor Spencer Flower, Councillor Terry Brooks, John Selgren, Nicholas Johnson, Anna Eastgate, and Chief Superintendent Richard Bell.
Thank you. And I'd like to ask if anybody has a declaration or any declarations of interest in relation to the agenda. No? Okay, lovely, thank you. Has everybody who was present read the minutes? Are you happy with the minutes? Yes, good, thank you. Thank you. George, do we have any public participation, any questions?
No, we don't.
No, okay, that's a shame. And no questions from councillors or any? No, okay. I don't have any urgent items. So we are actually now on agenda item 7.
Keep the pace.
Going through it. And I'm going to ask Sean Walker McAllister, who's online with us, who's the independent chairman of the Adult Safeguarding Board. I won't give the whole title, Sean, because it's, well, all right, Dorset, Bournemouth, Christchurch and Poole Joint Adult Safeguarding Board. I think that's
mouthful. Imagine having to have that on a badge if you had to have it on a badge.
Thank you very much.
This is, thank you. This is a statutory requirement to report to this board. So thank you.
Thank you very much, Councillor Somper, Chair, and thank you to everyone else for inviting me to present this to you today. So if I could have my presentation up, please, and then I'll assume everybody's read the report and there's just some key points that I wanted to highlight, if I may. I don't have the facility to put the presentation up, but it should be there. It's been sent in.
Oh, you've got your hand up. Is that?
It's in relation to the presentation because I was going to share it for Sian, but as a non-organiser of this meeting, it's not allowing me to share anything.
It's okay. You've got it. But thank you.
Lovely. Thank you very much, Claire, and thank you, everyone. So, yes, so this is our annual report. It's the annual report, may I remind you, for the period up till the end of March 2023. So we're reporting in retrospect. May I have the next slide, please? So the board, the Safeguarding Adult Board, has 3 key statutory duties as defined in the Care Act. It's to develop and publish a strategic plan setting out how we and all our partners meet our objectives and how everyone contributes. We must publish an annual report, and statute lays down that we must present that to the Health and Wellbeing Board after we've consulted with Health Watch about the report, and they were consulted in August. We also have a statutory duty to undertake a safeguarding adults review when somebody has died or experienced significant harm or neglect and it appears agencies have not worked effectively together. And may I also set out that the Care Act is very specific about safeguarding adults, slightly different to safeguarding children where everyone's included. In respect of adults, it's where adults with care and support needs who, because of those care and support needs, are unable to protect themselves from abuse, neglect and harm, come to our notice. Adult social care in both local authorities has the lead statutory responsibility. So again, unlike the children's boards, there are not 3 equal statutory partners, if you will. Adult social care takes the lead. And my role as the independent chair is to hold all the statutory and other partners to account to make sure that we're working in the same direction, working together, communicating and engaging well together to protect adults with care and support needs in our area. And may I also say that whilst a lot of our work can be reactive, for example, publishing a safeguarding adults review if somebody's died, actually our primary duty is to work to prevent safeguarding issues happening. And whilst that's not always possible, certainly the communication is essential to and the engagement to ensure we all work together. Our board has met. I've got a lot of feedback coming in. Sorry, I don't know whether. Shall I take my camera off for a moment? Our board has many partners over and above statutory partners, including ambulance, fire and rescue services, NHS provider trusts, voluntary and community sector. And we also work outside the board with faith groups and with further and higher education establishments and with registered social housing providers to make sure we bring into the round all of those who have contact with people who may have vulnerabilities and who will fit the safeguarding adults criteria and with whom we can promote effective safeguarding. So if I may go on to the next slide, please. So the slide I've included here is in total in the annual report. And whilst the Health and Wellbeing Board isn't just scrutinising Dorset Council, we thought it might be of interest to have the Dorset Council performance activity, and that's because, as I explained before, adult social care receives all the safeguarding inquiries. So it's adult social care which provides a safeguarding adults collection and annual return to NHS Digital for safeguarding provision within the county. So all these concerns that have been referred will not be just concerns about adult social care. They'll be concerns in respect of health partners, concerns for people who are not safe in communities, concerns with people who may not have services but who meet the definition of care and support needs. So those concerns will be raised into adult social care. Adult social care will undertake a triage and will spend some time considering whether other services may need to be provided either by adult social care in the form of a Section 9 Care Act assessment or indeed referral to an outside agency. And we'll also then decide whether the concern merits a full safeguarding inquiry. So this is the data that we collect in, and the data sheet before you sets out the sources of risk, the top 4 types of abuse and the locations of abuse. And I would say that whilst it looks perhaps not so good that 45% of sources of risks come from service providers, may I say that that's not a bad thing, that's a good thing, because what it shows is very effective engagement within Dorset of commissioners within adult social care and other parts of the system, engaging with providers to ensure they are transparent in reporting, as they should do under the Care Act, any concerns that they may have. And some of those concerns will not go on to inquiries. And it's fairly comparable with safeguarding data across the country when we look at similar large county authorities. In terms of the top types of abuse, again, the 51% neglect and acts of omission, that's fairly common. Self-neglect is normally the higher within that category, and that's much so the case across the country. And then locations of abuse, own home and care home, fairly high numbers there, and that's fairly common as well because of the frailty and people who are either living at home with many codependencies, comorbidities, and who will be living in care homes. Women twice as likely as men, often that's the age factor, and women living longer than men. And the outcome of Section 42.2 of the Care Act, that's the inquiries, that's when a concern has moved through, meeting all the criteria to a full inquiry. Risk removed 32%, risk reduced 66%, and remains 2%. I'm not concerned as your independent chair about those figures. We will never remove all the risks from individuals because individuals have the rights to be able to take unwise decisions. And our role is to ensure that in assessing those risks, that we undertake full mental capacity assessments where we are judging, or where professionals are judging, if people have the capacity to weigh up and understand those risks and understand the consequences of those risks before taking a decision to live in a particular way or take a particular risk. During 22-23, the board has been conducting 2 safeguarding adult reviews for Dorset, and neither of these are ready for publication. One has been through the final board and is almost ready for publication, but we're getting the comms plan ready at the moment, and it should be either by the end of the year or in early January, and that will be reported in the next annual report. So I hadn't intended to go into those issues today. The one has been published by the joint boards together, and that was a BCP safeguarding adult review. And we are also about and will be publishing the final stage of another Dorset safeguarding adult review. It was a very complex one that was undertaken in 2 stages following the death of somebody some years ago now. And where the inquest was held this year, and we split the safeguarding adult review into 2 parts. So that's something about the data. I will go on to the rest of my questions, but no doubt people will have questions about the data, and I'm happy to answer those then. Could we go on to the next slide, please? So what I have set out here, and it's in the annual report, and just highlighting it here for your information, is the strategic plan from 21 to 23. I was appointed to the board in 21. I inherited a strategic plan. We made some adaptations to it. And in March this last year, we held a development event with the board and re-energized and refocused the strategic plan for the current 3-year period. So that will be reported on in next year's annual report. So what I'm going to be talking about next, if next slide please, is some of the achievements that we've made in relation to the strategic plan. So we've done a lot of work with our community engagement group. It's always been my desire to engage better with citizens, particularly those who experience safeguarding interventions. That's very, very difficult, and staff are working hard in adult social care to ask people how they experience their safeguarding intervention. It doesn't necessarily mean that people or their carers want to take part in any groups or take part in anything after that. So we work closely with the voluntary and community sector, and through them, if there are people who would like to kind of join us and talk to us about some of the issues they experience, then we have the space to facilitate that within that subgroup. And the CEG, particularly in the last year, has taken a renewed focus and is now co-chaired by the community and voluntary sector leads for both Dorset and BCP. In the year going forward, it's chaired by the Dorset VCS person, Marie Waterman, and deputy chaired by the BCP person, as we move to a slightly different model for this year. We've worked with people from higher and further education. We were having regular meetings, basically to inform, educate, and to ensure that there's good communication around what higher and further education need to look out for in safeguarding issues. And a lot of that work arose from the BCP Safeguarding Adult Review I commissioned on Aziza, which is published on our website. It was a BCP review. And so we're not meeting as frequently, but we have good regular contact. And the further and higher education sector are a lot better informed in terms of picking up on issues and knowing how and where to report. We've also commenced engagement probably at the start of last year with the wider registered social housing provider sector, but this year we had an event which was highly successful And now the social housing sector itself is coordinating 6 monthly safeguarding events, which I will attend or other professionals will attend. And that was particularly well received to make sure that we're working efficiently together, that social housing providers who often have tenancy responsibilities for many people with vulnerabilities and care and support needs have good information and know how to engage with safeguarding when they need to. We published 7-minute learning papers. I'm a big fan of 7-minute learnings because a lot of staff working on our busy front lines often don't have the time in day-to-day work to maybe read a 70-page safeguarding adult full review, but they will have time to learn the salient points. So we produce these, and we plan to be getting these out one a month on various different issues, so that team managers can use them with their staff and then provide links to the more detailed reports that sit underneath them. This year, understanding homelessness and exercising professional curiosity were two issues that have come out through our safeguarding adult reviews and issues that we felt needed to have wider dissemination. We also publish a 7-minute learning paper every time we undertake a safeguarding adult review in itself, and recommend ongoing training provision amongst our partners. We've worked alongside the Dorset Healthcare Forum for professionals working with people with complex behaviours. We have delivered Safeguarding Learning and Safeguarding Adults Week, which is coming up again, but over this last year with keynote speakers, and very much supported by Devon Adult Social Care Training and Development to get a lot of this training out. So we're working hand in hand. We've developed an information pack for board members, so people are clued up immediately in terms of their responsibilities and accountabilities, both within the board and within their wider organisations. And I attended the Dorset Safeguarding Children's Partnership Executive Development event, and we work closely with the Children's Partnership and the 2 community safety partnerships, primarily to ensure we work efficiently together. We don't repeat reviews, that we agree where maybe a domestic homicide review is taking preference, and we'll ensure we participate in that through our representatives in adult social care to influence the terms of reference. So when it comes to the learning, we can passport that through the Safeguarding Adult Board. And we had a really effective development event with an external facilitator last year, who really helped us have a deep dive into the data and figures, and perhaps understand where improvements can be made. And that's been taken forward currently by the Quality Assurance subgroup. Next slide, please. These are just, I've talked a lot about this. So SARS we've published, we've delivered the training strategy, we've changed our business arrangements, we commenced work on aligning Dorset and BCP data with the NHS DICE information. So working very closely with the integrated care system and the safeguarding leads around using DICE to deliver an overview of our area strategically around information and trends to enable us to work with partners to help identify where certain pieces of work are needed. So that's been really, really good, and excellent partnership work with the Integrated Care Board and system in delivering some of that. We've updated our policy and protocols. We've got, I think, improved board member engagement. We have a renewed energy and good commitment, and assurance on delivery of making safeguarding personal, and that means ensuring we consult with individuals so that they have the opportunity to, where they have the capacity to be clear about that, to set out what outcomes they would like to achieve through a safeguarding intervention. Done a lot of work on that with the board. So next slide, please. So I've just my final slide here, which is key messages. So as an independent chair, and not all boards choose to have an independent chair. I mean, I guess I would say this, but I think it's really important. And, you know, I'm myself, I'm a former director of adult social services, so I understand what it's like to be in that role. But I hold all partners to account for delivering effective safeguarding strategies and services, and that includes Dorset Council as well. So even though technically I was appointed through the council offices, if you will, I've been appointed by the whole board, and it's really important that I ensure that partners join everything together. I work across the partnership. I'm striving for continuous improvement, and the data piece is really important so that we do understand the challenges, the trends, and enable us to have focused work on where we need to do preventative work. Lots of examples of join up, and this is this year, but I thought I'd put it in anyway. We've been working with the police on their delivery of right person, right time, which is a different focus on where and when police will become involved in areas that may include kind of adult social care, hospital care, mental health, and how we work together with our partners. And the police locally have presented this work I felt in a very collaborative way. So it's been important that we've had that opportunity to receive presentations at the board and take that forward, but more about that next year. And as I say here, much of the work is currently in training this year, and I've already mentioned about work with the community safety partnerships and the Pan Dorset Children's Safeguarding Partnership. So that's our year in focus, and I'd welcome any questions. Thank you.
Thank you very much, Sian. Any questions or comments? Sam.
Yeah, thank you, Chair. Thank you, Sian. I enjoyed reading the report. Every time I forget to do that. Sorry, apologies if you couldn't hear me clearly. Thank you, Sian. I enjoyed reading the report. I just had one inquiry about the performance information that I don't quite understand.
Yeah.
On the Dorset Council page, when you look at the inquiries that progress through to section 42.2, it says there were more than 3,000 other safeguarding inquiries and activities which Dorset Council undertake. And if you look at the information for BCP Council, it's completely different. It's 5 other safeguarding inquiries, and I just wondered if you could explain why those figures are so different.
So comparing local authorities with this data is like comparing apple, pears, mangoes and cherries, because different local authorities have a different approach at the front door. So what the figures you have for Dorset here are the figures that Dorset Council sent to NHS Digital as part of their annual return. And it's something that we looked at in some detail, given the stark differences. So thank you for picking it up and giving me the opportunity to explain. What Dorset Council wanted to do was to show the volume of work that comes in through the safeguarding portal, if you will, but actually doesn't require a specific safeguarding intervention, because sometimes people use the safeguarding portal to refer people in where there's concerns, but what they really need is a Section 9 Care Act assessment or a different type of engagement. Sometimes it might be a referral to Age UK for some voluntary and community sector support to enable a person who's not coping well on their own, for example. And what's really important is I think that Dorset has captured this data because it enables us to have a really good look down and see what's happening. So I'm not concerned. There is no right or wrong figure in terms of the percentage that go on to become Section 42.2 inquiries. And one of the things that that's one of my responsibilities is to ensure to have assurance, to receive assurance from senior officers in Dorset that they have audited and understand that the right matters are going through to more detailed safeguarding inquiry stage, so that relevant work can be undertaken with individuals. So not a concern. It's just that BCP Council report their data differently.
Okay, thank you, Sian.
Rita.
Thank you, Sian. Really helpful to read the report, and as you say, working really closely with the Children's Safeguarding Partnership. There were just 2 or 3 things I wanted to just highlight that we're giving
real conspicuous care to this year as well. So the local authority designated officer role within children's obviously looking to receive concerns or referrals on people working with children under 18. But I'm kind of very struck by, I don't think, unless I missed it, that the allegations against people in position of trust isn't captured in this report. But given those kind of numbers around events happening in care homes, I'm really keen, and we've had some live experiences of this, that sometimes, as we all understand, staff move between the two work groups, they don't stay in one work group. So just thinking about how we might bring those figures more to the fore. I see that they're in the ICB business plan around a key indicator, and I think they are a key indicator to make sure that the people in our county are safe, whether they're with children or adults, in terms of the people working with them. So just really keen to see that. And I don't know if you've got any kind of sense of that, Sian. And then secondly, just wanted to, for kind of information really, I'm presently, as part of the Pathfinder for Children's Social Care Change, battling against a very strong message from central government that you won't have an independent chair. I can't get to a policy rationale for this, if I'm perfectly honest, and I'm being very straightforward. But the requirement around that is to do not have an independent chair for the Children's Safeguarding Board, which I am, as I've said, battling. But just I would support that. I think it is helpful to have that independent element. And I know certainly as a DCS or DAS is definitely, because the determination is that the DCS will chair the Safeguarding Partnership. I think that's not, going to be suitable for any of us. So I just wanted to take that opportunity to get as many voices into that space as possible.
So thank you. On the first issue, as you know, Teresa, there's not the legislation in adult social care to have a LADO, a local authority designated officer, as there is in children's safeguarding. And in one of my former safeguarding partnerships, I chaired children and adults together. So in one board in Bath, North East Somerset. So I'm acutely aware of those issues. We've got a policy of persons in positions of trust, PIPOT policy, which is a Southwest. It was something that was developed with Safeguarding and Southwest ADAS, the Association of Directors of Adult Social Services, and Dorset Council, along with BCP Council and our partners, are working to ensure that policy, if not adopted as it is, in local policies with partners, they've taken from that to make sure that all the key issues are there. We haven't had any issues raised with the board in relation to people in positions of trust. But what I will do is take that forward overtly at the next meeting to follow that through, and we will ensure that we come back to and include something within the annual report next year, and I think that's very helpful. In relation to the independent chair, I suppose I'm a bit biased, and my interest is that I co-chair the National Safeguarding Adult Board Chairs Network, which is independent chairs in the main. And in some local authorities, increasingly, we're seeing a rotation of the DAS or DCS, the chief nurse and or the chief police person, rotating around that role. In my experience, if it is of interest to Health and Wellbeing Board members, what that means is that there's very often little continuity as the role merges around. I don't see how you can mark your own homework. I'm sure that's where Teresa's coming from in that. And interestingly, I have a view as somebody whom LGA commissions to go in to undertake safeguarding consultancy work with local authorities prior to CQC inspection, where it's sometimes difficult to get to the bottom of some issues where those arrangements exist. So I guess that's all I'll say on the matter, but I'd be really happy to talk with officers and members further if there's something that you would like to take a position on in Dorset outside of this meeting. But I absolutely feel very strongly that having an independent chair is important. And I guess for me, as a former DAS, but also as a social worker, still registered social worker who's worked in children's and adults, some organisations might be forgiven for thinking that maybe I'm biased towards adult social care within our work piece. I'm absolutely not, and I'm sure colleagues both in the police and in other non-statutory partners and the NHS will tell you that I'm very, very balanced in terms of the work that I take forward, as I would expect all independent chairs to be. And I think it's an important role that should be in this space. So I'd be interested to see how that develops in children's services as legislation changes or may change again in future years.
Thanks for that important question. Thank you. Julia.
Hello, my name is Julia Ingram. I'm Corporate Director for Adult Social Care Operational Services at Dorset Council. Just wanted to comment, if that's okay, on the LADO role. Just to confirm, Teresa, and also Sian, we do make use of the LADO in children's social care when we are made aware of somebody who's in a position of authority who's potentially putting a vulnerable adult at risk. If it is useful, I will start to capture that information within Dorset Council, and then Sian, that can feed into the board and potentially give you a benchmark. And Teresa, you're absolutely right. We have a responsibility across the whole system to make sure that we're protecting vulnerable people, because, as you say, people in authority do move around the system, and we have plenty of evidence to support that.
And Chair, if I may, I'll use this opportunity, or certainly going forward, for us to promote the PIPOP policy on the website and to ensure that we refresh in people's minds across all partner agencies the importance of the PIPOP, persons in positions of trust policy, and the necessity to make sure there's open and transparent communication between agencies.
Thank you very much. Are there any other questions or comments? No, just from myself, Sian, very pleased to see that working more closely with the housing associations. I think that's really vital. And I know it was spoken about at scrutiny, I think it was. So I was very pleased to see that piece of work. So thank you for that. Thank you for including that. I know this report is for noting, but I just want to ask if people here today and on screen feel assured of the work of the Adult Safeguarding Board, and they're happy to take that. Thank you very much, Sian, and Claire, thank you very much.
Thank you. Bye-bye.
Cheerio.
Bye.
Right, thank you. And now we move on. 8, which is the Better Care Fund, which is going to be presented by Sarah Sewell.
Oh, thank you. Thank you. Just going to share my screen. Just a few slides. Okay.
Just before, sorry, I should have said, just before you start, this is retrospective.
Yes. Yeah. So thank you. So good afternoon, everybody. I'm Sarah Sewell, Head of Service for Commissioning for Older People and Home First. And I've got a retrospective approval paper for you today. Before I just take you through just a couple of presentation slides just to summarise the report, I just thought it might be helpful just to do a quick reminder of some of the key features of the BCF. So I'm mindful that whenever I come here with retrospective approval. So it was just to kind of give you a bit of assurance of the work that's going on in the background. So kind of one of the key features or the main sort of points of the BCF is it's a mechanism which national funding is passed to us as a local system from government, comes into the health and social care system at that local level. So we have this retrospective approval, but there is strong governance embedded across all of the work. So we have sort of heavily structured and formatted templates. We report back to the national team at very set intervals and timescales, hence we get caught in this loop of retrospective approval because we can't get here quick enough for those timescales. There's strong regional assurance attached through the BCF process back to the national team. And at a local level for Dorset, we've got obviously the Health and Wellbeing Board, which oversee all of the work. We have the senior leadership teams across health and social care. We've got Joint Commissioning Board as well. So we've got a real sort of rigour around how we work through the fund. It requires us to work collaboratively and make joint plans for how we spend. The majority of the funding is long-standing, and we have that bedded into our business as usual budgets. However, we have, in the last sort of couple of financial years, government have used the BCF as a mechanism to pass on additional monies. So we're seeing more use of that mechanism as we move forward, albeit it comes with additional reports that we then bring back to you for retrospective approval again. But it's all good. It's all working in the right direction. So that's great. And you may recall from the last time I came to the board that we have, as a local system, added some new lines into the BCF, particularly that's supporting our sort of transformation direction around Home First, and also some BCSE working as well in terms of thriving communities. So just wanted to just sort of give you that sort of quick sort of context before I kind of moved on with the paper today. So as I mentioned at the last meeting, the board approved the plan for 23 to 25, and then at the end of September, NHS England confirmed that we'd passed all of the regional assurance and our plans have been approved. So that's great news for us moving forward. In line with our sort of prevention and preventative approaches, our BCF objectives really echo what we're working on locally. So that's around enabling people to stay well, safe and independent at home for longer, and providing the right care in the right place at the right time. And as you'd expect, the framework continues. So we have national conditions that we need to meet, and we have a set of national performance metrics that we report against. And we have approximately £146 million worth of funding that comes through for this financial year. So in terms of the report that you have today to consider, the Q2 report is a single document. It's Appendix A of your report pack, and that consists of several elements. We have to confirm that we're meeting the national conditions and that we've implemented those. We report on our current performance against the BCF metrics for Q1 and Q2. We give some narrative around our capacity and demand assumptions, and we've also done a refresh of that capacity and demand as well for that 6-month period. The BCF metrics that we track are around avoidable admissions, discharge to normal place of residence, falls, admissions to residential care, and reablement outcomes. And those, the falls are an addition for 23 to 25, but the others have remained the same over the past couple of years. So just in terms of where we're at in terms of our metrics, so we're on track with our targets around avoidable admissions, discharge to normal place of residence, and falls. We've put some real strong narrative into the return around our collaborative working as partners in meeting those targets, particularly around how we're working in communities to support and manage those long-term conditions of individuals. And we've also referenced the development of the out-of-hospital integrated care framework, along with the Home First model as to how we're continuing to promote and support people to regain and then maintain their independence. We're not on track around our rate of admissions to residential care. I just wanted to pause a moment just to give you a bit of context around that, because it's not as straightforward as it sort of seems in the metric as itself. So this metric, it's purely looking at admissions into residential care. It's not considering the overall movement. So we would have expected that with our stabilising home care capacity, admissions would therefore be lower. What we're seeing is that the admissions are continuing to rise. However, the population, both for DC funded individuals and also the overall care home population in the Dorset area, is remaining stable. So we've done a lot of analysis on this from an adult social care perspective. And what we know is we've got greater movement through our beds, and our forecasts are expecting that the length of stay is reducing, which is indicating that actually we're managing much better at home in the community. And when people move into care, into a care home placement, it's at a particular point in their life, and as I say, that length of stay is reducing. So we've been tracking through that data, and we'll continue to do that. And what we can see is, or what we know is, that the admissions arise from the community, so from home into a care home, from discharge, and also as a result of capital depletion. And that capital depletion is an area that as a local authority we monitor closely, and that is where people require local authority support to maintain the payment for their place in residential care. So we'll continue to obviously track that rate of admission, but we have, just to give you the assurance as a board, that we have that as adult social care, we have that greater understanding as to why we're off track, and it requires that broader context of what's going on in that care home space as an overall position. The other area that we are slightly off track on is around people's outcome after reablement. So people remaining at home 91 days after being discharged from hospital with reablement. We're tracking along the same performance as we were at the end of the last year, so 79% versus our target of 85%. We're really struggling with our therapy support. We're working really closely as a system, but therapists are in short supply, and we know that if we can support with therapy in that reablement space, that will support better outcomes for individuals. So we'll continue to, with our sort of collaborative approach as to how we can recruit therapists and how we can best deploy that resource across the system. And one of the areas that we're also looking at is using our reablement beds as a step-down approach before people return home. So that helps a more resilient kind of approach to maintaining and regaining that independence and then reducing readmission risks. So as I say, we have got a couple of areas that we're off track of, but we're understanding what's going on there, and we'll keep that under close review as an adult social care team, particularly as we move through to the next period. So as I referenced, there's an area around capacity and demand in the return. So just as a bit of information here. So as a home first approach, as a system, we've adopted discharge to assess, and we are seeing much more positive outcomes there. So we have more people returning home through our discharge to assess process. Our local home care market is recovering, and we have better availability there, and that in turn is offering better sufficiency and improving that flow, particularly Pathway 1, which is support home with a home care package. So as I mentioned, the demands and capacity modelling, we've refreshed that and given some narrative within that Appendix A pack. This was an area that we identified as needing some additional support as a local system, and the national team are providing that, and there's been an initial meeting to kind of work that through. So in summary, the Q2 report offers us the assurance that whilst winter will no doubtedly be a challenge for us as a system, the BCF plans are evidencing that we're prepared to respond to those pressures. So my recommendation is to please retrospectively approve the report template today.
Thank you very much, Sarah. Whiz through what is a very long, a very long, complex set of documents to read through. You have to fill in. So thank you for that. Are there any questions or comments, Sam, and then Tricia?
I had a couple of questions and a comment, really. The first one was about Falls performance, but I might be able to pick that up with you separately because I think it's quite technical about how we're reporting it. Okay. So if I can pick up, because it looked very good performance on the face of it, but it might just be how it's being captured and measured. The issue of therapy support, this isn't something I'm close to, but I did have a conversation last week with someone at Bournemouth University who was under the impression that a lot of their occupational therapists are training, qualifying, then not going forward into roles, and the commercial sector's playing quite a big role in that. So apparently a lot of them are going into jobs as assessors for private insurance. I had no idea. It's the first time I'd heard that. So I guess my question was, is it a shortage of roles, or is it that we've got therapy in the wrong place in the system, and it tends to be more of a, I guess, clustered around hospitals as opposed to working in the community, and what sort of ideas are being taken forward, I guess, through the people plan about trying to resolve that? It's quite a big question. Yeah.
So I can answer that, some of that in part. We are doing some work with Bournemouth University for that very reason, and we're very cognizant of the fact that people are training and then not coming into health and social care. So that's a joint bit of work that we've undertaken across the system with our NHS colleagues. So we are making those connections, because that is, that's complete waste for everybody's time and all that training. But also these are people that are local as well, and who are going into national roles. So we're very cognizant of that and doing some work on it. But I do think there is something about where are the therapists that we've got in the system and how they're being used. And I know that's part of the constant work that's going on across our system to look at, have we got people in the right places doing the right things early enough in the system to have the biggest impact? that is a continuous bit of work that I think we need to do. We're also undertaking quite a lot of work in terms of getting people onto apprenticeships and to making sure that we're sort of growing our own across the system and offering that as a real key role, and offering that as a role that works across both in social care and health. So people get the breadth of their experience, but we're not hanging on to people in the wrong places. So that it means we've got a deficit in advice, because it is having an impact, and it's a constant conversation, isn't it, that we talk about from a system point of view.
I think there's something about, just following on from that, we've been having some discussions with Bournemouth University about where they provide education from, because there's a really good case for a satellite unit in the west of Dorset that means that people don't have to travel in order to have their professional training, whether it's through an apprenticeship or a formal degree process. So we need to think a bit more about that. I also think there's a case for us to start talking about single workforces. And that's difficult because, people like to be employed by a certain organisation. But the way we get the best out of the workforce we've got is about the level of flexibility that we're willing to apply to it. And some of the younger, newly qualified people, actually flexibility is really important to them, because the likelihood is they're going to have 4, 5, 6 careers before they retire. So we've got to start to think about how we make that easy and how we use that electronic passport process to allow people to move between organisations and sectors wherever they need to start time. We've got a bit of work to do to think that through. The points I wanted to make were, there's a conversation happening nationally around how do health and local government use the BCF Section 75 and its widest sense to invest as much as they can through that route in order to fund joint transformation of service where it is needed. And I think there's something about us just thinking through what that might mean for the future of the way we operate as partners. And I sit on the National Discharge Task Force, which is chaired by David Bean, who's a NED at NHS England, but it has multi-sector representation on it. And again, we're repeating the conversation at the moment around how do we really get underneath the reasons why people are not discharged at the right time. They've produced a national data collection process to start to get on top of all reasons nationally, and that's fine. But the reality is they're going to be different in every place. They're different when we look at Bournemouth compared to Poole, compared to DCH, so there'll be different reasons. But what I do think that might do is really get underneath what some of the consistent solutions might be, aside from local variation, and inform what government does next around the long-term funding of what they're putting at the moment, which is not recurrent. And the conversation we were having at the meeting this week is, how do we get to a place where that work that is pushed by government focuses just as much on preventing admission as it does for facilitating discharge? Because the fact that the department has chosen to focus on the back door in the last few months has actually made the problem worse rather than better, because we need to get some balance in the conversation. So that was where we were on Monday. But we usually meet every other month. David will be taking that seat for me while I'm aware. So if there are things that you want to erase there or push through that task force, then me, and then when I'm back is the right way to get those messages in there, so we start to push those up to that national conversation.
That's something we all need to be pushing forward and thinking about putting those questions forward and those suggestions as well. Thank you.
It's really helpful to hear that, Patricia, because that was going to be one of my comments today. I know we always retrospective BCF, and I understand why. We do need to start to think forwards. How could we use the BCF as a vehicle or a mechanism to do things differently? And I was just going to do a shameless plug for Chris Whitty's report, which I think is quite interesting, about how we've kind of taken our eye off the ball of becoming an ageing society, and suddenly we're now dealing with the challenges, and the way that we think about services just isn't right for what's coming forwards. And I won't go into the report in detail, but he does say we need to really start to think differently about that medical model in later life. We more in probably health in older life, and we confuse frailty with multimorbidity, and they're not the same things. So there's some healthy challenge in that report.
Yeah, if you think about our particular demographic, that really is very pertinent. Paul, sorry, you wanted to.
Yeah, just got this. First of all, I mean, thank you for the report. And if I think about where we are now compared to this time last year, we're in a better place to sort of try and manage some of the escalations that people would experience over winter and the care that we need to provide them. And I think some of Better Care Fund, particularly things like discharge to assess, we managed to put in are positives of that. And without Better Care Fund, I think we would be in a much more difficult position. It doesn't mean that we're out of the hot water. And I know I can't remember your exact phrase at the end of it, saying that part of your presentation was that the better care, that we are prepared, or something like that, for to meet the needs through Better Care Fund. I think that might be a little bit overly optimistic, and I think going back and that bit that Sam mentioned about this, how can we be more creative? How can we use this even more effectively in that interface between health and care? So I think it's recognition of the benefit that we've got from it, but there's also, I think, a sense that that actually there's something more we need to do. A couple of other things. One of the things that we've had a conversation about internally, in fact, just this morning, is how we manage risk when it starts emerging in one part of our system, and how that drives or doesn't drive changes in behaviour and thresholds elsewhere in the system, in order to try and de-escalate that, even if we're lifting the risk somewhere else in the system, but actually the general risk is overlaid. And I think some of that needs to be thought about. Some of the things that we're putting in place associated with the Better Care Fund. We have a process that is fairly unique. And it's just thinking about how can we be flexible in the processes that we apply that allows a shift of risk around the system, even though it may feel a bit uncomfortable in one part of the system, but the overall benefit is there. And I think playing that in as to how we work that through will be really important. And the last thing around therapists, I think, we're working out where our therapists are. They spend an awful lot of time assessing, and assessing someone doesn't make anyone better. And the more we can trust assessments and not have to repeat them as people move across the system, the less we're going to be looking for our therapists and other healthcare professionals to be doing those assessments, and more they can be actively treating and improving people.
I agree with that. And I think that's why I say using our therapists flexibly will be good for them to be exposed to a different level of risk taking outside of hospitals, because I have no doubt that, be careful what I say, it's a public meeting. I have no doubt that sometimes the expectation that's put on an individual is way beyond what they could even achieve before they entered hospital, and that then delays their discharge. So, trying to get people as exposed as we can to how different sectors manage really important if we start thinking about moving forward with sort of the dynamic risk assessment that's being discussed nationally. But one of the conversations we had at the national discharge meeting this week was me raising the fact that, yes, we do need to sort out discharge, and we do need to understand what drives the delays, but we also need to start to think more about, when we've tackled that issue, actually what's the support, the early intervention upstream that prevents us from getting there. Otherwise, we still keep perpetuating the same problem rather than starting to plan it out of the system. And what I'm really refreshed by is that in the planning guidance that comes down for integrated care systems, probably not until after Christmas now, it's very simple. It asks for a number of delivery mechanisms to be put in place in systems. And one of those is the work that we've already started, which is the integration of neighbourhood teams. And once we start to see those coming together with primary community social care, physical and mental health, then we're starting to get on top of supporting people to live independently at home and not doing what we do now, which is fixing the problem after it arises. And I think as part of that work, we really do need to challenge ourselves in terms of Chris Whitty's report, particularly
we over medicalise problems, and this idea that we use frailty with, Sam said, with multimorbidity, is an opportunity for us to really crack that problem as we start to move forward that integrated model.
And we've spoken, or it was spoken about previously in another forum, really, about the speed in which this is being done here, and actually really understand it, not just rush in. So just having that focus on an area where there are really some very big issues and problems, and learning very much from it, and then spreading it out. I think you're totally right on that. Yes.
Yeah, so Simon Raw, hi, Chair of DCA, and here as a representative of the voluntary sector. So I'm going to make a plug for the voluntary sector in this space, because it plays a huge and massive role in discharges and keeping people beyond those 91 days. And you know, be it somebody popping in for a chat to help address their mental health, be it sorting out prescriptions, be it driving them to appointments and making life possible once they've discharged. And of course, if they've been in hospital for a lengthy stay, there's a danger they'll become a little bit institutionalised, will take quite a little time to adapt, and it plays a massive role. And I know, Sam, you're touching on this and looking at this as it thriving communities work. Yeah. So, you know, I think within this, that shouldn't be forgotten. And if I can make a shameless plug for the work that is being looked at in with Simone Ewell and one or two others around Sturmiston Union, which is looking at how to engage the voluntary sector and working with GPs and local PCNs and Dorset Council to make that process a little bit more effective and make it work better. And look at bottom-up solutions, recognising that communities are very different and the needs of communities across Dorset are very different, say in rural Dorset to the middle of Bournemouth town or Poole Town Centre, and how that might work. So top-down approaches can work and give a lot of benefit, but we shouldn't forget the benefit of people just doing good things in our community.
Yeah, and I support that. Yeah, it's probably.
I think also the work in the prevention gaps is also really vital for our VCS and in our small communities. I know that from what I see for myself. So yes, the out of hospital and all that kind of area, but also that prevention of getting into it, particularly around people who are isolated, lonely, that self-neglect, those areas which we spoke about before. I think it's absolutely essential, and it's very much at the front of many conversations. Sorry, Patricia.
No, I was just going to say that the work on the development of neighbourhood team bottom.
Yeah.
And I think we'll probably end up with 50 plus neighbourhoods as a result, because the neighbourhood needs to be the neighbourhood that the community define, not the neighbourhood that we define.
Absolutely.
Yeah, thank you. Just something that just kind of has been, I suppose, troubling me a bit about how we need to change up the conversation with our people generally, and children and adults in terms of some of that. And it came out of actually a presentation around dentistry recently, but I was struck by the same kind of issue here in terms of this over-medicalisation. And I remember the kind of gasp that went around the room in the dentistry conversation, but you don't need to go to the dentist every 6 months, you have to go every 2 years. And I felt like I declare myself fallen off the angel shelf Catholic. And when they told us later that there was no such thing as purgatory, I remember thinking, oh my goodness, how can you change the rules like that? Now, those of you who aren't Catholic won't know the significance of being brought up in purgatory, and, well, not quite like that, but and then being told, you know, thing as purgatory, and thinking, but I've been living by that. And so it kind of really strikes me about how are we having those conversations about actually, you know, we've learned, we've changed, we've developed, we kind of have a different expectation now. And so the 6 month, 2 years kind of dentistry conversation is a big change in lots of our communities. And I don't think it's landed, if I'm honest. I kind of talk to lots of families and they're going, and equally, I don't think the concept of actually the first response to having a problem in your body doesn't need to be a medical response has landed either. And so it's not a question for this board. Sorry, Jane. It's just a thought that's kind of been rambling around my head.
I understand. Thank you. Is there anybody not in the room. I can't see any hands up. I don't know if anyone want to comment. No? Okay. Thank you. Well, thank you very much for bringing this. I know it's retrospective. I know it's all noting. No, I need a proposer and a seconder. I do. I'm happy to propose. And just a second. Thank you so much. And for filling in all those forms.
Need to say I don't ever be office because I don't understand any of these processes, so they'll constantly be saying to me, propose second.
So we're going to move on to item 9, which just a little explanation of why I requested this come here, actually, because it was going to go to the Joint Public Health Board, which was postponed. And I felt actually there were some really important points in here that this was a good space for it to come to. So I used my chairman's prerogative to do that, but in conjunction with discussing with Sam, who thought, yes, that is actually, it is a good space. So I need to ask Sam to introduce that.
Thank you very much, Chair. Sorry, I should have said before, I'm Sam Crowe, Health, and it's very rude of me not to introduce myself right after the meeting. I'm really pleased to be sharing this report information with the Health and Wellbeing Board today. I was going to kind of talk a little bit around health checks, if that's okay, because I've been involved in them for a long time, and I have quite mixed feelings about the position that we're in today. So the Chair is right. This was due to go to Joint Public Health Board in October. It was going to report on progress across the first 2 quarters with a reset NHS health checks programme. And we're going to take the report in December, but this is just looking at the performance in the Dorset Council area. So hopefully you've had a chance to at least scan it. Background is it's been a nationally mandated programme for years. It was, I think it's one of the last things that the Labour government did, which shows you the age of it. So Gordon Brown supported this idea that we would have a national risk assessment for cardiovascular disease, and that anyone who wasn't currently identified with a circulatory condition would get the chance to be invited once every 5 years for a simple risk assessment. And if you reached a certain level of risk, then that would be a conversation around next steps. Some people might then go forward for testing and end up being managed by primary care. Some people, it might be a conversation around their risk factors, which is a bit more of a health and wellbeing, public health type conversation. I have to say, it's been very difficult to run this programme right since its inception because there's been no central call and recall system. So unlike cancer screening, where there's a central registry and a single process is run that make sure that everyone's invited once every 5 years, we have to rely on general practices and we have to work with their data. It takes up a lot of time, and it also means that we aren't really assured that people are being invited once every 5 years, because what happens is you move, new processes start, and you're trying to look at lots and lots of different ways of inviting people. And even before the pandemic, we had a programme that I was concerned was delivering lots of checks to those that had lower cardiovascular disease risk. So if you look at the proportion of people that would come forward identified as reaching that threshold of risk for concern, it was about 3% in many of our communities. And in some of the more deprived areas, we had next to no delivery at all of health checks. So I was concerned from an inequalities perspective. What we were doing was seeing lots of with very, very low, not actually delivering in deprived areas. Delivery stopped in the pandemic, and that was the opportunity for us to step back and say we need to rethink this. And a couple of things then guided the way that we thought about re-establishing the programme. The first was we no longer have a budget that's adequate to cover everyone. So if we're going to invite everyone once every 5 years, deliver a really high quality comprehensive risk assessment, that's becoming difficult to resource through the current budget. And we needed to think differently, I think, about not building in this perverse incentive, if you like, that we're supporting lots of communities who probably don't need the checks and not delivering to communities that do. So the model we came up with was to start to think differently about how we use the budget, and we agreed through the Joint Public Health Board to leave around 2/3 of the budget with primary care delivery and to put about 1/3 of the budget into Live Well Dorset. And Live Well Dorset would then devise a new programme, which was very much about offering an outreach programme where they could turn up in community venues, link with other groups in the community and offer people an opportunistic health check, which we thought was one way we would like to assess whether they could really reach some of those communities. So the report presents the first 2 quarters information. You can see it's a mixed picture. So while there's been improvements in certainly activity compared with the previous 3 years, it's still patchy. There are some primary care networks where there's a low volume of checks being delivered, particularly the Blandford area, East Dorset, Mid Dorset, Weymouth and Portland. But that in turn will be the focus of the new Live Well Dorset outreach service, and we're partway through mobilising that. And we'd just like to, I guess, keep that assurance focus on whether it's really delivering. One of the issues that we do know from previous community campaigns is that when we run campaigns in the community, the proportion of people who are identified at risk tends to be around about 20%, with standard delivery in more affluent areas, you'd be finding about 3% of people at risk. So it is quite a big difference. Mm-hmm. And we need to keep monitoring who we're finding and whether that outreach programme is able to deliver at scale. So I'm happy to kind of pause and take questions on the information. The other reason for bringing it to the board is just to make partners aware, and particularly around the engagement with the Live Well Dorset team and how you can find out where and when they'll be. So thanks to our comms lead, Lucy Mears. She's just got a couple of points, which if it's helpful for me to share with the board, sort of explain a bit more about how we develop that engagement. So they have a training and engagement team, and they link with events in the community. They've been linking up with COVID vaccination clinics, for example. So just as the vaccination program's thinking about groups that are perhaps harder to reach, they'll also piggyback onto the back of those clinics. They've been working with our locality team. So each of the localities has a public health officer that supports the primary care network. And they've been looking for opportunities to bring the checks with an understanding of what's going on in the community. And they've also been running a workforce offer, which has been quite successful. I know it's been in Dorset Council. It's also been in BCP Council in some of the place services. And they're starting to link with Dorset Healthcare. NHS Dorset, I believe, are also going to have a workforce series of checks, and some of the other providers. But probably the biggest way of getting in touch or understanding what's happening is through the social media. We run quite an active social media presence. So if you look on our Live Well Dorset social media, Facebook pages, they've got details of the events that are coming up. So if partners are interested, either to join an event or if you've got suggestions about events that they can come and be at, then the team would love to hear from you. So that's all I wanted to say, Chair. Thank you.
Thank you very much. And thank you for bringing it. Paul.
Thank you, Sam. And as you say, you've been doing this for many, many years. So the last thing you probably want is a newcomer coming up with all suggestions about how you could do it different. But
That's why it's here.
I think there's a set program that comes with this, and I guess one of my questions is, how flexible can we be locally around the flex, including the criteria that have to be built? Because if we look at what are those things that are going to make the biggest difference, the biggest one is blood pressure by a long way compared to all the other things that are in there. And that doesn't need anyone qualified or trained to do. That needs a blood pressure machine that someone can stick their arm in, and then that report going somewhere. So I wonder whether there is flexibility in here to pick off the key indices that are going to make the biggest impact and do those first, and then grow that way. And then the second thing is, I guess there's a challenge about using general practice, given that what we're trying to do is effectively an unskilled type of screening. Because what I want our GPs doing is looking after the people where a risk has been identified and getting it under control. And at the moment, we're not doing that as well as we should do. And Patricia and I went to a GP practice, a PCN, just last week, and I won't say which one, but you have already mentioned them, where actually they just said, look, we haven't got the capacity to do the blood test necessary to titrate people's blood pressure to get it measured. So actually we can bring them in and measure, but we're really stuck as with the capacity to do anything about it. And if we've got somewhere saying that, then I would really love to say to them, okay, well, let's, like Live Well Dorset, or let's actually, if you find another mechanism that says we can identify people's blood pressure and we're going to help them monitor it in some way completely separate from you, and I want you to focus on the medicine bit of things that is involved in getting that blood pressure under control. And so I guess, can we be flexible in order to be able to drive what we think is going to be most effective?
That's a really valid, important point. Which is, you've been reading my notes.
So the short answer, yes, I think we do need to be flexible. I think it was a programme designed in a bit of a different time, and it's not kept pace with the reality of where we are now. So I think there are some things that we could do as a system which start to put the right resources in the right place, in the right setting, where you can get much more value around it. And without being hugely prescriptive, I think there's something about using platforms like DICE to see if we could do centralised invites, because we could invite based on an understanding of risk, based on information that's already in the primary care register. It takes a small number of people to do that rather than replicating it across every single PCN. I think the points about blood pressure, I completely agree with. The NHS Health Check was a sort of branded quality assured programme. It's got a whole load of quality standards that if you're going to call it an NHS Health Check, you have to comply with, particularly if you're going to go out and procure that as a service. But finding people at risk of high blood pressure is what we should be doing as systems anyway. So I think it would be really helpful to look at how are we using our total resource and where are we directing it to have the biggest impact. And NHS Health Check has its place, but we could definitely look at tweaking it, changing it. So I'd be up for that.
Byron, Councillor Quayle, I see your hand up.
Thanks, Jane. And actually, that was a great question that it just came up, and I appreciate the reply, because it did feed into something I wanted to raise. I know, Sam, you say that particularly in the north there are some areas with low turnout. Well, if in Blandford there is no turnout, which I was quite shocked at, to be fair, because particularly how the PCN has grown here and takes up quite a large rural area as well. I did challenge them on this and said, you know, what on earth are they doing? Because I believe they haven't taken this up. And it comes back in that point that was just made that, you know, they said that they just didn't have the capacity. And then there was a conversation of exactly what you've just gone into. So it's great to hear what you've just said about, well, how do we look at this differently? My concern with some of the plans going forward, particularly in the Blandford area, is that some of the people that we want to see who would be at risk and really are the people we want to get into this, you know, they don't use social media. They, you know, the group practice does a lot of stuff. They have, I have a local surgery that goes down to their sort of Wellbeing walk-in clinic thing that we do on the last Tuesday of the month. But it misses swathes of people because, you know, Blandford is a mile from the top down into the marketplace, etc. And I personally, as a local councillor, there's about 25 people that I look after or always put my, you know, knock on their door every 4 weeks because they fall out of any sort of monitoring by our social services, but absolutely need support. So my challenge to the PCN and effectively what I'm coming around to is it's great to say, oh, right, fine, in Blandford we will eventually get to do something, because I was completely shocked to see a big fat 0. But people that we actually really need, there's a number of categories. There's people that fit in that category that we need to see, and they probably will engage. But the people who probably we really urgently need to see aren't going to engage. So how do we get around that? What mechanisms come in? Because I didn't see anything that actually drilled into that level of it.
Thank you, Byron. Thank you. Patricia.
So I'm probably going to say something slightly controversial now, as usual, but actually I think there are 3 categories of people. There are those that
we need to see that'll turn up. There are those that we need to see that won't turn up. And there are those that are more than capable of making a decision that they don't want to turn up. And we spend the whole of our lives in the NHS behaving like we're a safety net for every single person in there. And actually we can't be. So there are some points where we have to say that, yes, we can respond to people who are unlikely to come for treatment, but we can't force them. Mm. And there will be sections of our community that are more than capable of making a sensible decision for themselves that they don't want to engage in health services and health checks. And we might not agree with that, but we have to respect it.
I don't disagree, but I think the point also that Byron is making there is, if you don't know about it, if it's not being out there, but there will always be people that just don't want to, aren't interested,
and we can
can deal with those things.
We spend a fortune sending the same letters to the same people that we've already been to their house and engaged with, because we just don't want to accept that they don't want to engage with services. And so I think we need to find a way of getting the balance right.
Yeah.
Oh yeah, Simon Raw. So I just wanted to kind of pick up. I had the privilege of being on car park duty in Broadstone the other day I think now it must be a Live Well event that was organised by the local PCN. It was a Saturday morning, 9 till 12. We must have had 300 or 400 people turn up. Didn't have enough room for them to park. They were forming long queues to get in. A lot of support. I did hear at the time people comment there was a similar event at Blandford that hadn't been nearly well supported. People were quite shocked at the level of support. But I do wonder if you've got 2 very similar events that are working in two communities, just looking at what was different between the 2. Why did one get zilch and why did one get 300 to 400 people turn? I think there are lessons to be learned there. I also totally agree with what Patricia was saying, that people have to take some responsibility for their health, and it cannot act as a safety net for everyone in that respect.
Thank you. Paul.
Sorry, we could carry on with the conversation for ages, because I think it is really fascinating. But I think one of the things that, and I agree with you, what Patricia says, but the thing that we need to hold on to is that the model that we are using doesn't then represent a barrier to people who otherwise would access the screening. So that's the bit about thinking differently. We mustn't say, well, we've put it on at a PCN and we put it on in a car park and they've not come up, so we've done our bit, because I think that's too short-sighted. But as you say, there is a limit around chasing, but we've got to meet people where they're at and respond to how people engage with the world around them, rather than assuming they're going to engage in a model that we set up.
Opportunity for access it is essential, and I think I suppose the reason that I felt it was quite important to bring this here today is really around. This is about prevention, totally about prevention, and we talk about it all the time, and that's why it's so essential. And I felt that the take-up was disappointing. It was something that we should air and look at opportunities of doing something differently, which have been brought up and explored. So I feel it's been very helpful. Sand.
Thank you. I was just going to come back and kind of answer Councillor Quayle's really, really good challenge. So I don't know the detail, but I'll go away and I'll find out what's been going on in Blandford and exactly what the Live Well Dorset team have been doing. And this is the reason why I want to keep this under the spotlight, because they're learning as they're going along. So we need to understand who they're seeing, what seems to be working. That's very useful intelligence. So there have been two quite big events, and why were they different and why were they supported differently? So I think in this paper, we only actually had Q1 performance information. We're nearly in Q3, so we will keep looking at it. And I'd be really pleased to bring a very short paper back that perhaps talks a little bit more about the community outreach aspect, because I think it is really important.
Can I just ask, will that be going to the Joint Public Health?
It's going to the Joint Public Health Board again on the 7th of December.
Is that the next quarters coming through?
What I'll ask is for a presentation on the board, so that the paper will probably be similar, but you'll actually have some slides on updated information.
Brilliant. Thank you.
But the other thing I wanted to say in response to Councillor Quayle's challenge, what we do is we look quite closely at the burden of cardiovascular disease in communities, and Blandford wouldn't be one of those areas at the moment that I'd be concerned about, but I would be concerned about North Bournemouth, I'd be concerned about Central Bournemouth, I'd be concerned about Bournemouth East, because when you look at the standardised adjusted rates of admissions for heart attacks, those are the communities where you tend to see higher age-adjusted admissions. So we do keep quite a close eye on what's happening at the wrong end of the spectrum, and are we trying to get an appropriate offer in those communities where we know that the risks of poor outcomes are higher. So it's not saying that it's not important to have a good programme in Blandford, but it's probably lower down on those lists of communities where I'd be more concerned.
That's interesting, Sam, because I'm not. I mean, that's obviously what data is telling you, but it's also about, of course, people are not being tested, then we don't know what we don't know. And in the prevention area, if people are coming in and the blood pressure is high, they didn't know that necessarily, then they can take steps to deal with that. But it's based on data, right? I understand. Yeah.
Yeah. We've got that at ward level.
Yeah, I accept that, but I would also say a zero is you're not going to get any prevention information or that early raised pressure that you can then deal with very simply. And that's just Teresa.
Yeah, thank you. And I guess those numbers are they per 10,000 or are they kind of total numbers would be the other thing that's interesting, because I think the perception in some of our rural areas is that it is an issue. I think that's the interesting thing really about kind of smaller communities probably. But I was just thinking that a quick solution presumably is to give Councillor Quayle a machine. And I'm saying that both lightheartedly and seriously in terms of actually, if you think about what we've done with the DFibs and other things around communities.
GP surgery, do the wrong.
Yeah, absolutely. And just so
take them out of GP surgeries.
Take them out of GP surgeries, exactly. Yeah, because the DFibs aren't in the GP surgeries, are they? Yeah, genuinely. I mean, actually a real community response. I mean, there are those of us that have got, those fancy watches that do it for us. And, there's some interesting elements, I think, about how do we get that into the communities that don't have that affordability of access.
Vivian.
And we have a lot of potential to use our care homes differently and our community centres, don't we? Where we know that it's they're there. People are there, or they come to. Yeah. So how we use our tech, I think needs a lot of. Wouldn't take much thought actually when you think about what else we're doing in those centres. Exactly. So it's an opportunity.
Yeah, I agree. I think we better stop now on this, because otherwise, as Paul said, we could really start to delve down. But I'm glad that it's come forward. Thank you, Sam, and it's had a good airing, and there's some interesting suggestions that come forward, which you might be able to consider, Sam, moving forward. Thank you. So now we move on to the work programme, agenda item 10. George?
Yes, thank
you. Help on this?
We've got a couple of items on the work programme at the moment, only around place-based partnerships and integrated neighbourhood teams. But we had a conversation last week about various other topics going forward to the meeting in March, and we've got quite a few at the moment. So we'll have to prioritise which items we've got going forwards to the next meeting.
Do you want to give us a flavour?
Yeah, so
we discussed.
We've got the potential update on 5 in the communities, the Births Adulthood Project, the Families First for Children's Pathfinder, joint strategic needs assessment, and the refresh of the health wellbeing strategy. And the other item I had was right care, right person, which is being led by the police.
That's a lot there. Mark, do I have to think about that and any preferences for priorities? Because I don't, that would be heavy. It's the gap in between, isn't it?
Yes. What's the date of the next meeting?
March, mid-March, I think.
Yeah,
middle of March.
So the Children's Safeguarding Annual Review, his annual report is going to Cabinet in January.
Right.
So if you wanted it to come here, then it would still be sort of question up in March. That could come alongside the Pathfinder, because those have lots of implications in terms of things I was mentioning earlier, and that might be sensible. Apologies, microphone's up. And I think the other thing that I was just thinking around is the board. So the Pan Dorset Safeguarding Partnership receives the local authority designated officer report. So the LADO report we were talking about earlier in terms of allegations in the system. So just wondering whether that could come again alongside the report. That report's just been now for the year. So I'm just trying to think. I think we could bring a few things together which would be up to conduct.
Yeah. Okay, there's a lot to think about there, George and I think we have to try and prioritise that, because we won't be able to bring all of those. There's some important.
And the right care, right person is not going to be fully implemented until January of 25. No. So you could delay that to the meeting afterwards if you wanted to.
Yeah. We can discuss that, George, and all those others. Will there be any more retrospective better care funds? All right. Okay. Well, we can have a think, and anything people think as possibilities to come forward then, but yes, then moving forward, obviously. There's no exempt business, so I am going to close the meeting and thank everybody for being either here or on screen. And have a good Christmas.